Thank you, Shashi. Good evening, everybody, dear faculty, and the students who have joined the webinar. A big welcome to all of you for this 240th webinar that we are holding today. This is the consecutive webinars that are being held on Wednesdays. And today, I'm very proud that soon we will be finishing 250 of them in another 2 months' time. Today we have a very good case discussion, and which is a virtual one, of course, but it will carry a lot of importance to all the students. Their take-home messages that they will receive from these ardent neuroanesthesiologists. The senior anesthesiologist, Dr. Kakkar and Dr. Anshul Yadav, will be moderating, and Dr. Kakkar, who is the moderator today. Dr. Mukul could not come. Professor Kapoor was busy. So Dr. Gaurav Kakkar is a very senior and neuroanesthesiologist in Amrita Hospital. And so also Dr. Anshul Yadav, he also is in neuroanesthesiology and critical care. And what are we going to discuss? This is a case of fracture dorsal spine for fixation, where the presenter will be Dr. Sweta. She's an associate consultant in neuroanesthesiology and critical care in the same hospital, Amrita Institute of Medical Sciences, Faridabad. So let's begin. Sanish, do you have any other slides that you want me to project? I would just want to inform all of you before we start this case discussion that we have a new venture that we have started, and this will be held in April, the ICA Olympiad 2025. This is to encourage the students who are either the final years or any of the postgraduate students who want to test their ability and where they stand in the national forum of all the student anesthesiologists. So this ICA Olympiad 2025, this has got this an icon where you can register for it, and the programs are of course there, and you can register. This is the scan for payment. Look at the interesting prizes. The first prize 50,000, and this is for several questions that will be asked as an exit examination. So it's a very thoroughly planned. We will be having practice sessions, how to understand this whole ICA Olympiad. The results will be out, and then you can, of course, judge where you stand. So you have mock examination so that you are prepared how this whole examination will run. So I would encourage all of us, all the students to join, and also please request all the seniors to encourage their students to join this program, which is going to be held in April. Coming to the ICA Con 2025, which is being conducted for the last 15 years. So this will be the 16th National Conference of the Indian College of Anesthesiologists, and it's also the 6th International. This is being held in Jodhpur and organized by the Department of Anesthesiology, AIMS, Jodhpur. And here again, we have on the website, you can register and you're most welcome to join. It'll be a very interesting conference. The conference of our in ICA have actually reached a standard where they are highly appreciated. So again, we welcome all of you and request you to register as soon as possible. Our Indian College of Anesthesiologists has started the New Delhi PG Assembly, and this again has been very popular. It was started last year, and the students have given a very positive feedback for this. And this is going to be held from 25th to 29th April in Delhi, in the UCMS and GTB Hospital. Again, all the details are available on the website, and you can register for it. So please, students, go ahead and do it. So coming back today, thank you so much. Let's start with our ICA webinar with the case discussion, case of fracture dorsal spine for fixation. Thank you so much. We may start, Gaurav.
Sure, ma'am. Thank you so much for those kind words, ma'am, and the proud history and the contemporary vision of ICA. It's a pleasure to be part of this and to be presenting our case. We got a message of presenting a thoracic case. So Dr. Sweta, will be presenting a case, and which we recently managed. It's actually, we haven't made up any images or cases, but this is an actual case that we managed recently, and it'll be quite interesting. So I'll let Dr. Sweta start, and then we will discuss about the case during and after the session. Thank you.
Good evening, sir and madam. My case presentation today is on anesthesia for thoracic spine surgery. I'm Dr. Sweta Shah from Neuro Anesthesia team from Amrita Hospital, Faridabad. Uh, Case background. A female patient ages 75 years complained of lower backache since 1 month and unable to stand and bedbound for 10 days. She was a known case of hypertension and diabetic for 6 to 7 years and was on oral medication for hypertension and oral hypoglycemic agents for diabetes. Her clinical examination, general examination, no history of pallor, jaundice, ictus, clubbing, edema. His vitals were stable. She weighed 65 kg and height was 150 centimeter, which stand for BMI 28.9 kg per meter square. On systemic examination, first was central nervous system. She was conscious oriented with full GCS, that is 50 by 15 by 15. Power, both upper limb and lower limb, was 3 by 5 after examination. Spinous process tenderness over D11 and D12. VAS score was 8 by 10. Respiratory bilateral air entry was present. And cardiovascular system examinations, S1 and S2 sound were heard. On airway examination, mouth opening 3 finger, Malampatti grade was grade 2. No loose tooth or denture. Neck movement was adequate. Thyromental distance 6.5 centimeter. Sternomental distance 13 centimeter. Mandible protrusion was normal. Initial clinical examination, MRI was done to rule out the problem of the patient, which shows D12 osteoporotic fracture. It is an MRI in view showing D12 fracture of the D12 fracture of spine. Blood investigation. Pre-op blood investigation was done. All the OT protocols was done. All the reports was normal and within normal limits, but ECG shows ST changes. As you can see, the ECG of the patient which shows ST depression in V1, V2, V1 to V6 leads. Cardiologist, we refer the patient for echo. Echo was done, which shows 30 to 35% ejection fraction. We advise the patient for cardio reference. After seeing the cardiologist, the cardiologist advised for DSC, which came positive. Then the cardiologist advised for angiography. Angiography shows stenosis in major vessels. As the patient was suffering with major vessel obstructions in heart, and patient was an age-old patient. So what to do next was the question for us. So after discussing with surgeon and cardiologist and optimizing the cardiac treatment and keeping in mind the patient's health and condition, it was first decided to go for angioplasty. Then after 3 months, it was decided to go for the surgery. But as the patient was in immense pain, and she was in old age, so there was much complications, and the attendant also want the treatment early. So after discussing with surgeons, cardiologists, and with the neuroanesthesiologist, it was decided and suggested for surgical management first. Then we can go for angioplasty in the
Okay.
same admission.
Sweta, just let me stop you there
Yes,
at
sir.
this point, and let me ask you the things that you brought out in the history and the examination. So even before you decide for the surgery, what were the concerns of the patient in the history and the examinations that you find out as
So
a
first,
anesthesiologist managing this case?
first the patient was an age-old patient. There was an old age complications. Then after pre-op examination, as there was a low ejection fraction and spine surgery was done in prone position. That is also a major concern for the anesthesiologist. Um, Age-old complication as patient fragile bone health function, heart function. It is the main concern for the patient.
There are problems with geriatric age group. So it already has age on his side, diabetes, hypertension.
Yeah.
Alongside that, you had systemic problems. If you were to go break the patient into different systems, you had a big problem with the cardiovascular system.
Yeah, sir.
And a positive ECG, and that when you investigate, you turned out and you found out from a positive VSC, and that turned out to be
Yeah.
this problem. One thing that will influence your decision making for such patients is social history. What did you find on the social history that was missing in the slide? Could you tell us what was the social status of the patient in terms of mobility, in terms of what the patient was able to do or not do, because that has a major bearing on the decision.
Patient was bed bounded, not able to walk.
So the bed bound patient.
Sorry, sir, can you increase the volume? Sorry.
Sorry. So this patient was a bed bound patient, not able to do
Yeah,
do her daily mobility.
yeah, sir.
Dr. Anshul, can I bring you in here? Okay, so till Anshul joins, how do you think that affects our decision making for a complex patient when you have such histories? Sweta?
Uh, Sir, there's a hemodynamical instability in cardiac patients. Um, as a surgery has a blood loss, effective blood loss, so which affects cardiac function of the patient. As patient is already low ejection fraction, there might be problem during intra-op.
Okay, so for all the trainees listening, whenever you answer a question for the exam and for the case also, we can divide the problems into patient-based factors and the surgery factors. So the patient-based factors here are geriatric age group,
Geriatric age.
cardiovascular disease, polypharmacy, and a limited mobility and limited exercise tolerance, etc., and the social status. So we have to be practical in terms of what we are dealing with and how much can we offer. So the indications for surgery was actually pain relief
Pain.
by the surgery so that the patient doesn't have to stay in pain and wriggle in pain and be bed bound. Now, if you look at surgical factors, the surgeons can promise maybe kyphoplasty, maybe fixation to this patient. But if you marry that to all the comorbidities and the problems that the surgery itself has to bring, as Dr. Sweta said, you got to prone the patient, which brings itself all the problems of proning, plus the problems of major fixation, blood loss, etc. Would this be a good candidate for this surgery? Probably no, considering all the comorbidities and the DNA. We had to make that decision right here as to how far can we go with this patient. We can't just simply say no these days, and probably correctly so, because we can't afford to let the patient be in pain. So first tell us, Dr. Sweta, what is kyphoplasty and how were you able to offer to the patient what you wanted to offer?
Mm. Okay. First, the plan of the surgery was kyphoplasty. It is a process where cementing was done in the fracture level of the patient. As the patient has D12 fracture, it was done cementing First ballooning, then cementing was put in the fracture area. So the decision for kyphoplasty angioplasty, same day prioritizing the patient's health and condition. Kyphoplasty done under high risk consent under MAC in prone position, then patient taken for angioplasty post spine surgery. Anesthetic consideration, cardiac risk management, prone position challenges, hemodynamic stability maintenance, airway management strategies, and osteoporosis. Anesthetic management, kyphoplasty done in MAC. We usually do kyphoplasty in sedations where awake arterial line and IV access done under local anesthesia and mild sedations. We then prone the patient for surgery, and intraoperatively we TCI pump used for propofol and intermittent bolus fentanyl given to relieve pain during incision and during trocar insertions. During cementing, we should maintain normal volume, increase inspired oxygen concentration to 100% and maintain blood pressure stability. These are the articles supporting the kyphoplasty in IV anesthesia or in sedation or in GA, general anesthesia also. These are the steps of kyphoplasty. First picture shows the ballooning. Second was cement insertions, and the third was post cementing. Cementing was done. Post-op recovery, post-surgery, patient recovered well and was able to walk pain-free. No immediate complications was seen. Complication of kyphoplasty, bleeding, infection, nerve damage, bone cement syndromes, cement leakage, and pulmonary embolism. This is the picture which shows the one of the complication of kyphoplasty. Recently, a kyphoplasty was done in our OT, and there was a cement in the lungs, which it is a post-op X-ray, which shows the cement particle in the lungs. Patient was suffering from respiratory distress. So this is one of the complication of kyphoplasty. Follow up. After patient return after 4 weeks with a complaint of progressive weakness of both lower limb from hip with lower back ache from past 6 to 7 days. CNS examination was done, which shows hip power and knee power 1/5. Um, then MRI was done to rule out any proximal lesion or compressions, worsening or compressions at D11 or D12 level. And then we done an anesthetic checkups. Anesthetic evaluation main concern was patient was on dual anticoagulant. As 1 month ago angioplasty was done. How to proceed? So
Stop you here before
yes,
you
sir.
proceed with this. So, so we did the kyphoplasty, and
Sorry, sir, it's not been heard.
we did a kyphoplasty followed by angioplasty
Yeah.
at the first stage. Is that correct?
Yes, sir.
Okay. So before we move on, I want you to tell us and all the viewers, how did you decide what to do first? We could argue if the cardiac status safer.
Sorry, sir. Can you repeat once? As the voice was not coming properly.
I said, why did you went ahead and did the kyphoplasty first and the angioplasty?
Firstly, patient was bend bound and immense pain was there. And in angioplasty, heparins, anticoagulants were used. And post that, first I to first doing angioplasty, there was a risk, more risk of bleeding in the patient. So we decided to go for kyphoplasty to first treat the complications of surgeries and to treat the patient's condition. Then we decided to go for angioplasty to prevent bleeding, more bleeding.
That's correct. So once we had found out that she has a major cardiac problem, we were stuck with the decision whether to do the cardiac part first or the kyphoplasty first. We obviously took a multidisciplinary team meeting along with the family's wishes and the patient's condition. And once you do the cardiac stenting that she required, coronary stenting, obviously she would have been on antiplatelets and we wouldn't have been able to do our vertebroplasty or kyphoplasty at that stage for obvious bleeding reasons. So it was decided that under high risk cardiac consent, along with cardiologist's advice and family's wishes, we proceeded with the kyphoplasty under sedation. And on the same sitting, we did that in our radiology suite. We then got the patient back to supine from the prone position. And on the same sitting, we took the patient to the angio suite where the cardiologist did the coronary stenting.
And
Went uneventful. And then we discharged the patient after 2 days. So this at this stage, this was a standard kyphoplasty vertebroplasty for us on a usual high-risk patient, which are generally prone, who cannot withstand fixations or have prolonged surgeries. So we treat these as necessary procedures for pain relief so that they can get about and do about their daily life.
Sir, Gaurav, sir, your volume is very low.
Right. I am on maximum volume. I apologize.
Yes, sir. Yes, sir. Now it's better. Yeah.
So we do these kyphoplasties. I won't say as palliative procedures, but as procedures primarily for pain relief, accepting high risk under sedation. In this case, the risk was even higher because the patient needed to have coronary stenting done in the same sitting. So we did that multidisciplinary team and did it after the procedure. And we thought it was over, that we've done the stenting, the vertebra was expanded, the pain relief was there, and now the coronary stents were there. So we discharged the patient after 2-3 days where the pain was good and she was mobile. But our problem did not end there, as she bounced back after about 4 or 5 weeks, again with some other problems, which now Dr. Sweta will highlight again. Thank you.
patient returned with complaint of progressive weakness of both lower limb from hip and lower back ache from past 6 to 7 days. This time also pain was immense. Patient was suffering from immense pain and not able to walk properly as before. Then we decided for surgical management, that is D9 to D12 augmented screw fixation and D11 D12 decompression under general anesthesia. But as we know that patient was on dual anticoagulant, same risk was again with bleeding. So after discussing with surgeons and cardiologists, and patient's attendant was keen for the treatment as patient condition was is not improving, not improving. So it was decided to go for the surgery under high risk consent using bridging therapy for anticoagulant medicine to prevent the complications of anticoagulant medicines. Anesthetic consideration, optimizing diabetes and hypertension before surgery, ensuring optimal control of patient's cardiac condition, managing the effective dual antiplatelet anticoagulant therapy, airway management, hemodynamic stability, prone positioning, and intraoperative monitoring. Anesthetic protocols, induction and maintenance, positioning, intraop monitoring, and blood loss management was the main concern for us. Anesthetic management. As patient was on dual antiplatelet anticoagulant, we started on bridging therapy to prevent any uh, complication. Under high risk concern, patient was induced with propofol and TCI pump, fentanyl and atracurium. We gave USG guided erective spiny block for pain management post the induction. Maintenance was done with propofol and TCI, fentanyl, and inhalation agent. This is the article of bridging therapy we used. We stopped the dual anticoagulant 6 to 7 days before the surgery, And we started a bridge with low molecular weight heparin 24 hours post-operatively. Then 12 hours we stopped the low molecular weight heparin, and we gone for the surgery, keeping bloods and FFP, RDP, all the blood requirement keeping in hand. We proceed for the surgery. These are the steps of decompression and fixation, and the picture of post decompression and fixation. Post-operative evaluation, patient was in ICU for 1 day for close monitoring. For pain management, fentanyl on PCI pump was attached. Patient was able to walk next day pain-free. No immediate complication was seen. Started on dual antiplatelet 12 hours post-surgery. This is the post-op chest X-ray. We usually do post-op chest X-ray after the OT or before the extubation to see any complications of fixation or cementing during the post the surgery. Complication of spine surgery, bleeding, infection, pneumothorax, incidental durotomy, and pulmonary complications. Thank you.
Okay, Dr. Sweta. So when we decided this patient came back, what was the single major concern for you? What was the single major concern for you to give the general anesthetic for the fixation?
So, as patient had already angioplasty 1 month ago, and patient was on dual anticoagulant, so this was the major concern for us,
You
as
mean
there
dual
may be
antiplatelet?
immense bleeding in during intra. Yeah, dual antiplatelet.
Okay,
Antiplatelet. So main concern during was bleeding due intraoperatively.
good. So what steps did you take, or what was your strategy to minimize this risk? How did you manage this part? Just elaborate
Uh,
that on first.
yeah, sir. We decided to go for a bridging therapy. We
Okay,
stopped the antiplatelet 1 week before the surgery and started on low molecular weight heparin.
okay,
And we done PTINR APTT we monitor basically the INR of the patient during this 1 week interval of the surgery. Then
okay.
24 hours before the surgery, we stopped 12 hours before the surgery, we stopped the low molecular weight heparin and gone for the surgery post 12 hours.
Sure. So INR would not be affected by your low molecular weight heparin. So we can't check the functioning of low molecular weight heparin by that. Any other steps you can think of what we did that helped you in these right from start before you even did the surgery or anesthesia? So we decided to again have a big multidisciplinary team, called everybody together, including the family,
Yeah.
because it is very important to be clear in our heads what is the indication for this surgery, and everybody understands the risk. So clearly here, again, the patient was again bedbound, was unable to move, and the family was desperate, including the patient, that they were not accepting this patient to remain bedbound and have all the complications of being bedbound. So they understood that it was a high-risk cardiac case. The cardiologist was also on our side and understood that it has to be done and we have to find a middle way. So we stood the bridging therapy with double dose of low molecular weight heparin. When I say double dose, it was a BD dose. And we stopped the dose 24 hours before the surgery. And again, another important step was a big discussion with the surgeons beforehand, where they also understood that they cannot be a long procedure, a usual long fixation procedure that can last 5-6 hours. So there has to be a quick in and out surgery with minimal possible blood loss, so that the patient who's already frail, already on blood thinners, already compromised, has the best chance of succession. So it was the best hands for the day should be doing the surgery. We shouldn't let anybody who's less experienced, with no offense meant, but the best hands possible, the best hands team does the operation so that the insult to the patient is minimal. We can operate, come in and come out quickly. And that's what happened on that day, where after everybody on board understanding the risks, we did the best for the patient in terms of preparation, delivered the surgery in under 2 hours. There was minimal blood loss. And luckily, when we did an erector spinae block, you gave a PCA, the patient had an excellent wake up and an overnight stay where it was heartening to see her standing up and sitting on the bedside and having.
Hello.
Sir, you are inaudible again. Gaurav, sir. Yes, sir. I think so. There is some network issue with Gaurav, sir. Dr. Sweta?
Hello?
Yeah.
Am I
Hello.
audible?
Yeah, now
Yeah,
sir
sir.
is audible. Yes, sir. Yes, sir. Now you're audible.
Yes,
Okay,
sir.
so Dr. Sweta, would TEG have been helpful to you if there was bleeding in such cases?
Sorry. Hello. Hello.
Yeah,
Yeah,
sir
am I
is asking
audible?
about the role of TEG. Yes, thromboelastography.
Yes, sir.
So I think another useful thing was a thromboelastography, which we were to use if there was bleeding, but luckily for us, there wasn't much bleeding. But TEG is a very useful point of care test that we can do, especially in
Yes.
such cases,
Yes, sir.
to maximize our therapy for bleeding.
Yes, sir.
So with this, I'm sorry that I'm traveling, so my voice is sketchy, but I'd like to invite everybody, if they have questions, or are there any questions from the audience or from our esteemed faculty, I'd be more than happy for opinions from Dr. Jayashree and Dr. Mulidan. Please, anybody please want to join?
So, yes, sir, can we elaborate what was the intraoperative fluid therapy for this patient like? Hello, am I audible, sir? Sir, Dr. Sweta.
Sir. Hello.
Can we just elaborate what was the intraoperative fluid therapy what was given to
What
this
was the
patient?
intraoperative fluid therapy? If you can answer.
Yes,
Yes.
sir.
Hello.
Yes, Dr. Sweta, please continue.
So intraoperatively, we provided the patients warm fluids like normal saline or ringer lactate. Hello.
I mean, considering the ejection fraction of the patient, did you rely more on blood
Uh,
products straight away, or did you go for non-blood crystalloid products?
we go for non-blood crystalloid product as there was a minimal blood loss. So we provided colloids plus crystalloid both in moderation.
Okay. Any, ma'am, dynamic parameters of fluid therapy use, non-invasive or invasive parameters?
We we were using arterial line
So
for
that's a very good
BP.
question. that for such cardiac patients, we need to have advanced monitoring. So all we had was an arterial line and a central line. Obviously, a central line would not give us true parameters of filling, but it is sorry to say that we did not have any advanced monitoring available for us to use that day. So we just had an arterial and a central line to do with. And as far as the fluids used were concerned, if I remember correctly, we total used about 2 liters of fluid, of which 500 was a colloid and the remaining was crystalloid, as Dr. Sweta said. And we didn't have to use any blood. But I would have been very happy to use either a Litco or a Pico or an esophageal Doppler. But on that given day, we had none available. So we got on and did that.
Okay, sir. And sir, any specific inputs regarding post-operative pain management in this patient?
As we have given an before starting operation, we have already given erector spiny block, and the surgery was very short period. And we have kept the patient in ICU for 1 day for pain management, and we have attached PCI pump for fentanyl. So there was no pain as such was complained by the patient. So block and fentanyl release the pain of the surgery for the patient.
So if I can answer in 2 ways, I would first take the pain for kyphoplasty. So the pain after kyphoplasty is actually non-existent. The moment the cement goes in, there is hardly any pain post-operatively. Some people only have some pain during the balloon dilatation because of the stretching of the vertebral body. So that intraoperative fentanyl and an IV paracetamol at that stage take care of that pain, and they hardly have any requirements for post-operative pain after the kyphoplasty or the vertebroplasty. At the second stage during fixation, our spinal protocol is to give ketamine, low dose, fixed up to maximum 30 milligrams under midazolam cover, which we give, which she had. We also gave her an erector spinae block. This was not ultrasound guided, this was blind. But yes, ultrasound guided in people who do ultrasound and get guided can be better. This was followed by a multimodal ladder with paracetamol, which she had preemptively, and followed by a fentanyl PCA. So this whole modality works very well for us, and she post-operatively only required 3 demand doses of the fentanyl PCA overnight. So there was regular paracetamol post-operatively, every 6 hours, 1 gram, which was tapered to 1 gram 8 hourly. The fentanyl PCA was hardly used, which is our 500 mics in 50 ml. So only about 3 doses were used, which comes to about 60 mics overnight. So that just shows that our erector spinae blocks, along with paracetamol and a ketamine. The noteworthy thing about ketamine is that it must go before the skin incision. So it must go before the NMDA receptors are activated. If the ketamine is given intraoperatively, in our experience, or later on, the best benefit is lost, then the dose of ketamine required goes up, and we end up in problems of post-operative hallucinations and etc. So there are other things available for the enhanced recovery package of spines like magnesium and lignocaine, which we did not use in this case. But the ketamine, PCA, and the paracetamol worked well for us here.
So there are no more questions as such from the audience, and you have already highlighted all the points of ERA's protocol. How should we plan earliest possible recovery of this patient post-operatively? All the points have been covered. So I guess this is all from the case point of view.
Sure.
Yes.
So there's another thing I would want to highlight for thoracic spinal fractures and fixations would be this incidence of pneumothorax. So especially in this era of minimally invasive spine surgery, wherein a lot of devices have come in and it's being done under navigation, we as anesthetists need to be extra cautious about what is happening with the pleura. So, especially with thoracic segments getting involved, we have seen at least 3 or 4 cases in the last 2 years where inadvertently the pleura has been damaged and the patient has had pneumothorax post-operatively. So, at least 2 of these 4 patients we had to rescue with a chest drain. The other 2, we just watched the small pneumothorax dissolve over the couple of days. But this is a point to be kept in mind that especially when this elephant arch rods with navigations or the 3D guided screws go in without full exposure, we can't assume that the navigation is 100% correct or the person using the navigation has got it 100% correct. So if you see any respiratory parameter changes or especially different patterns of breathing in the immediate post-stop, even before you extubate, then we must have a chest X-ray if you've not picked up already a pneumothorax. So a couple of our pneumothoraxes we picked up on the O-arm when they have done, which is essentially a CT scan. But the one in which we had to rescue, we had a big suspicion when the pattern of breathing was not right. And the patient had to be rescued by an urgent decompression because of the big tension in pneumothorax was there. So since then, we have a protocol where we do a post-op chest X-ray in the immediate post-op before extubation where possible for all thoracic fixations or anything that has touched the thoracic column where pleura could have been damaged. That is something I wanted to add.
Yes, sir. We just have to be careful that geriatric population is increasing throughout the socioeconomic strata of our country. But such cases should be taken up only where we have tertiary care centers. We have the backup of, thoracotomy and cardiac surgeries available. This one thing can be included in planning. But of course, we are all at tertiary centers, but such patients are increasing across all the kind of medical facilities.
I can't agree with you more because there are problems of plenty with such scenarios to be managed in the spine. But at the same time, there are problems of polypharmacy, there's problems of geriatric age group, there are problems of multi-system involvements, and the neurological insults that are there with the spinal injuries. So that's a big gamut to manage in itself. But at the same time, I think not all patients would be reaching this far because most of these patients would stop at kyphoplasty, vertebroplasty level at this age group because the aim of the operation is to provide pain relief. So that still needs to be done at a higher center because it in itself has a lot of complications to offer. But we are going to see this, as you said, more and more. But this is something we need to train ourselves further because we shouldn't be denying these elderly patients pain relief because that cementing is their only pain relief. Otherwise, they'll be bedbound and have all the complications of being bedbound.
Very true. And Gaurav, yes, those patients whom we can't operate, otherwise major surgery, as you said, kyphoplasty, yes, and it can be done under local and a good sedation in case they are not fit for GA, am I right?
That's right, ma'am.
Basically, the idea is to get them ambulatory as fast as possible. So true. What about the monitoring that you all do, Sweta? Routinely, are you doing all the monitoring? The
Yes, ma'am. Routinely, almost all cases we do intraoperative monitoring, BIS
Ah.
entropy. Usually we do, ma'am.
we do that as a routine.
Yes, ma'am.
Right. The motor or the sensory?
Um, uh, Especially the sensory one.
Okay. Right.
So yes, ma'am, we are using intraoperative neuromonitoring
Yeah.
for spinal cases, and it's both motor and sensory.
Right.
From
And
our end, we are using BIS.
okay.
We have actually the entropy version of BIS. So we are
That's
using we use a balance anesthesia with propofol and minimal volatile to get through that, and
Yeah.
waiting for remifentanil to do full TIVA. But We have a
Yeah.
recipe for TCI propofol and a minimal MAC to get through this.
That's true. Very. And who does the monitoring, Gaurav? You all or the neurophysiologist comes?
No, ma'am, we would say we have enough on our plate, so we let the neurophysiologist do it. So
Okay.
I know, I mean, I have not been trained to do neurophysiology as such, so
Yeah.
I have raised my hand that I can facilitate the anesthesia, but that should be a separate neurophysiologist to do it.
Sure,
So I
right.
know there are places where the anesthetist does both the ends,
Yeah.
but I am incapable of
Right,
that.
but no, it's not. I agree. It's not fair. If you have to do it, you must have another
That's right.
anesthesiologist. You can't be doing so many things. True. Vineet, are there any questions there? Hello, Vineet. Gaurav, are there any questions? Dr. Anshul, are there any questions?
No, ma'am. No, ma'am. No questions from in chat rooms.
Okay.
No questions in the chat room.
Okay. So maybe we can just summarize and I can conclude the session.
Sure, ma'am.
Yeah. So this was an
So to
excellent.
summarize,
Yeah.
you want us to summarize the case, ma'am?
Yeah, sure.
So to summarize, we had a elderly 75-year-old lady with diabetes and hypertension, whose coronary artery disease got diagnosed during the PAC workup for a kyphoplasty. Now we were stuck with the decision for kyphoplasty versus stenting, and we decided to go ahead under high risk to give her the mobility status where a parallel kyphoplasty followed by immediate coronary stenting was done. This we thought was the end of the day, but then she bounced back after 4 weeks with continuous compression and pain and being bedbound, which pushed us to do the thoracic decompression and fixation, again under high risk, with the provisions of bridging therapy because we had to stop the dual antiplatelets from the coronary stenting. So, highlighting this case, we have challenges of these elderly patients which will keep coming to us with problems of osteoporosis and fractures. We need to manage these kyphoplasties under sedation and be aware of the polypharmacy and the risks involved. Thank you.
Thank you, Gaurav, for summarizing the case. So for the students, you have come to know how challenging these cases are. And as has been highlighted, they should be done in tertiary care centers because each and everything was important. Even the stenting that the patient was on a dual antiplatelet, all those guidelines have to be remembered when we are doing such cases. And Gaurav and Dr. Anshul, both of you have moderated the case so well. And Dr. Sweta, thank you so much for presenting it for us. And
Thank you.
I must say it's her first case presentation ever, ma'am. She's just joined us and she was part of the case. Well done, Sweta. You'll only
Yes.
learn from this.
Very good, very good. Keep it up, and you will always remember, of course, your teachers, but the Indian College of Anesthesiologists also gave you this chance to come on this platform. So great, all the best, Shweta. And thank you so much. Thank you so much, Dr. Gaurav and Dr. Anshul. Thank you so much. I know you had such a busy day, but you managed to join. Thanks a lot. Thank you, Shreyasi. Thank you, Vineet and Sanish. And we'll see you next Wednesday, same time. Thank you very much. Thank you. Good night.
Thank you. Good night.
Thank you so much, everyone, for giving us the opportunity to host the session. So, with this, we are concluding the session over here for today. Thank you. Good night, all.